Good morning, Excellencies, ladies and gentlemen. I would like, on behalf of my co-chair, to welcome you at this plenary session, number 2 today, ending preventable child death within the continuum of care. I think that this has been already raised. We need to work within the continuum of care and also within a global stage or system. I would like to thank the organizers, the people from head of the UN agencies, but also minister of countries like India and Ethiopia. I would like to also thank you for giving me the opportunity and the honor to co-chair this session with my friend, Dr. Flavia Bustreo, Assistant Director General in WHO. She's in charge of a lot of things, including family health and child health. And I would like to thank her for being with me today and trying really to moderate this session. We all here are committed to child survival. We also are all committed to redouble efforts to enable countries to achieve the MDGs 4 and 5, but by 2015, but also beyond. We would like to have further reduced of under 5 deaths. We need to turn this vision into action. And it is why we need to respond to the how. It's good to think and to look at a vision, but we need to implement and to do things and to act in countries particularly. It is why our session will focus during 1.5 hours on the greatest challenges, direct or indirect causes, and also on strategies to help really end child death. But for this, we will have 5 speakers, and very well known, and you see them on the table, but you will know them better, I am sure, when we will be introducing them. But let me introduce first our first speaker, Amie Batson, Senior Deputy Assistant Administrator for the Global Health at USAID. Amie, you have the floor.
Thank you, Minister. Good morning. So what I wanted to briefly start with is just a quick overview of what is this roadmap that you have all seen and that was referred to and discussed many times yesterday. To start with the roadmap is first a huge point of thanks. So many of you in the room, what the roadmap is capturing is the data, the analysis, the pioneering efforts that you've taken in countries, in districts, to show where we are, the knowledge that we have, what we've seen that works and doesn't work, and what we may need to think about differently. So this roadmap is really taking an accumulation of the collective wisdom across our community. Next slide, please. Just to remind you of what we saw yesterday, we are not on a trajectory, we're on the red line right now, we're not on a trajectory to achieve the MDGs or to achieve what the world can of ending preventable child deaths. And the importance of the world's need to bend the curve, to work differently, to accelerate the rate of reduction so that we are moving more rapidly. And the big question becomes, how quickly can we work? How quickly can we move to be reducing that rate of child death? As our first panel pointed out, we know what are the causes of death. We've made tremendous progress, and now we can see the picture of what causes are remaining, with 4 neonatal conditions, pneumonia, diarrhea, and malaria, accounting for over 75% of under 5 mortality today. But we also know that there are very important underlying contributors, particularly nutrition and healthy timing and spacing of births, that are extremely important as we look towards accelerating this progress. Our data has shown the tremendous disparities that exist, and only focusing on a national average doesn't really get us to where we need to be, and to see what is happening in the rural and urban poor areas where often we see some of the highest burden. The roadmap is emphasizing the evidence-based interventions that we have across the continuum of care. We are very fortunate, and it is why we can hold up a goal like ending preventable child deaths, because we have this incredibly strong arsenal of solutions to address the existing causes. In fact, if we look at the 75 countdown countries, we can see that by scaling up some of these most proven cost-effective interventions, including vaccines, bed nets, basic nutrition, family planning, we can actually have a tremendous impact on the existing mortality, a 2/3 reduction. And by addressing many of the other issues with new technologies, girls' education, inclusive economic growth that were referred to yesterday, we can drive even further. So it brings us to the what do we need to do differently? And yesterday there were a number of strategic shifts, the 5 strategic shifts that were identified, of things that we in our community know we need to be thinking about and addressing in a more focused fashion. 1, geography, and ensuring that we're aligning our efforts where the burden of death exists most. The 24 countries that represent 80% of child deaths, and the 5 countries that represent 50%. Second is this recognition of the disparities, that we have high burden populations within every country, and we need to be refocusing our systems to reach these underserved, the rural and the urban, poor, and most vulnerable. Third is the focus on the highest impact solutions. As noted along our continuum of care, we have the solutions that will address a vast majority of the deaths we see today. So ensuring that we're targeting those biggest opportunities, for example, neonatal conditions, that we're looking to scale and sustain the demand and the supply. I think what's come out very clearly is, as the minister just referenced, we know the what's. We know what the causes of death are, and we know what the solutions are. Where we need to be focusing our efforts is on the how. How are we scaling up those interventions to reach the child, to reach and empower the mother, the family, and the community, so that they can make the behavior changes, they can access the services, they have the necessary awareness. Fourth is that this isn't just a health issue. Child survival, the neonatal child maternal survival, goes beyond health. And in fact, it very much depends on investments in girls' and women's education, on the type of social changes to ensure women are empowered to make good decisions, and enacting the smart policies to ensure inclusive economic growth. And lastly, and I think what was the theme of all of the presentations yesterday, is that of mutual accountability. Ensuring we have even greater transparency, and we are holding each of ourselves, as well as each other, accountable for progress. That we're unifying behind with a child's survival voice. And that we're investing in the necessary systems to capture the data and to monitor our progress. What's exciting are the number of partners that we have in the child survival space. But many of us don't actually report against the child survival goal writ large. And one of the signs of success will be how we report against specific interventions or diseases, but also how that contributes to the bigger goal of accelerating our progress in child survival, accelerating the rate of reduction. Mr. Lake laid out yesterday the promise renewed, and the 3 very critical actions going forward. First and foremost is that this is all about each country's and their own plans, and ensuring the countries have any necessary data or help to support them as they sharpen those plans, implement them, and set their own targets. Second, the issue of transparency and accountability, and using all of the systems that we have to sharpen and improve and build upon them. And third is mobilizing all of our efforts in a collective action. So at the heart of the global roadmap is the data, the analysis, the case studies that you all are doing to tell us as a collective community where we are, where we need to go, and what we need to do differently to get there. The global roadmap is only as valuable as it is a reflection of the wisdom of this community. It is a living document and needs to be updated to reflect the latest data, the latest progress, our latest picture of where we are going so that we can move forward. Thank you.
Oops. Thank you, Amie. I don't know how we will. But thank you for sharing with us really this 5 strategic shifts and also collective action on 3 fronts. I think that this is very important, and as Minister Tedros was saying just a few minutes ago, it will be important for countries to own it and see what they want to do with that. And this is why it is important also to know how we will accelerate progress with more efficiency and innovation, but also maternal education, and this will be discussed with Chris Murray. Chris, you have the floor. Chris is the director for the Institute for Health Metrics and Evaluation at the University of Washington. Thank you.
Thank you, Awa. And what I'd like to do in this presentation is basically touch on 3 themes. The first is, what can we understand about the broad drivers of the historic decline in child mortality that we've seen in the last 4 decades? That's been a recurrent theme in both this morning and yesterday's comments. So, as is the wont of people with a lot of data available, there's been a whole series of statistical econometric analyses trying to pick apart why has child mortality declined globally in so many countries, faster in some, slower than in others. And I'm not going to go through the econometric details, but the answers that you get from that type of analysis, using many different approaches, tend to tell you 5 important things. First, there's a very strong relationship, as I'm sure many of you know, between the levels of maternal education and the death rates of their children controlling for everything else, such that a year more of schooling has a very substantial effect on child mortality. Second, being richer is good, and there's a relationship between national income per capita and child mortality. But that relationship is not so huge. A 50% increase in income per capita will lead to about a 6 to 9% decline in child mortality. So if we're thinking about how to accelerate progress, hoping for enormous economic growth would be good, but it's probably not the key strategy to achieve that acceleration. The third thing on this list is the obvious, which is spending more money on health. And so again, you can study a little bit less robustly because there's a shorter amount of data about health expenditure, including development assistance for health. But nevertheless, you see a relationship, as we would hope. You spend more money on healthcare systems, we see faster rates of decline. But again, that relationship is not so enormous. If you increase health expenditure per capita by 50%, you'll probably have about a 7 or 8% decline in child mortality. So that strategy also, buying your way out of high child mortality, is a very expensive strategy. Now, the fourth item that comes out from this sort of analysis is one that I think is very relevant to everybody here in the room, which is one that Sam Preston, a famous demographer, observed nearly 4 decades ago. Namely, the whole relationship between child mortality and after you control for income and education and health expenditure is shifting. child mortality is lower each decade for the same level of income, education, and health expenditure, and a number of other determinants like disasters, wars, or HIV. That shift is ascribed to enhanced know-how, innovation, or knowledge. And so although we can't point our finger at what is the innovation, what's very clear is the whole relationship is shifting over time, and that pace of innovation, new tools, new ways of delivering services, new ways of reaching disadvantaged communities, is actually one of the most powerful drivers of the trends of the last 4 decades. And I think that's an important lesson as we think about acceleration. The fifth part is shown on this slide, and that's actually the efficiency of health systems. How well do health systems take resources and, taking into account income and education, all these other factors, translate that into progress on child mortality? And perhaps not surprisingly, there's huge variation, as shown in this map, in efficiency, with the countries in red being the least efficient and the countries in blue being the most efficient at reducing child mortality, controlling for everything else. What goes into efficiency is, what type of interventions? Is it the right interventions, getting to the right children? But it's also quite dominantly how well organized and managed are health systems. And that missing part of the efficiency of health systems turns out to be one of the most powerful levers, I believe, for accelerating progress in the future. Okay, so here's what will happen to child mortality, not based on the observed trends in child mortality, but based on these relationships to income, maternal education, to innovation, as well as to health expenditure, holding efficiency constant. That we would expect, if the trends that we observe in countries hold constant for those drivers, that we'll reach a child death rate in 2035 of 27 per 1,000. So that would be 12 per 1,000 away if we had a goal of reaching 15 per 1,000 for the world. So that's sort of the baseline where we stand, given what the econometric type analyses tell us. All right, second, and this is the level of child mortality according to that baseline forecast that you would see by country. Many countries with quite far above the goal, let's say, of 20 per 1,000, if that's what the goal were. Well, what do we know about the potential for acceleration? Bob Black talked about evidence that some causes can go down very quickly, and I'm going to touch on that theme, trying to show what Bob was showing in a slightly different way, but the same message. So first off, there have been some countries, as everyone's well aware, that have had quite dramatic paces of decline. Here's just some of the countries that in the period from 2000 to 2010 have had, for all causes of child mortality, rates of decline of more than 6% per year, which puts them at a pretty high rate and would be the types of lessons we want to learn and spread to other places. If we switch to looking at cause, and here's just one way to visualize causes, it's a rectangular pie chart. And I'm going to show you in a moment, in honor of our chair, or co-chair, our Coll Seck, the estimates in this rectangular pie chart for Senegal. So here it is. Here's Senegal. And this is Senegal in 1990. Each box is a different cause of child death. And if you were sitting close to the front, or we had a bigger screen, you could actually look at what some of these are. The box on the bottom right is malaria. And what I'm going to ask is the person at the back to play the video version of this. We can actually do this through the internet, but the technology hasn't worked out. So what we're going to see is the causes of child death composition in Senegal changing over time. From 1990 to 2005, where malaria became quite a bit bigger, and then going to 2010, where malaria declined, and there's a shift in the cause composition of diarrheas and pneumonias. And I only show this to say that the advent of much better information on cause of death, like Bob was showing earlier, by country over time, allows one to try to explore some of the determinants of acceleration. And in fact, if we look across countries, next slide, if we can get back to the slides, you can sort of summarize the different country experience in reducing child mortality by cause in this one slide. This is at the global level, but we can do this for each country. On the x-axis is the opportunity for acceleration, where the causes on the x-axis tells you how fast can you actually make a cause decline, and the y-axis is how big is a cause. And you'll see up on the top right there that malaria, the cross, has a huge potential for accelerated decline at the global level, given what we've observed in countries. And then it is also a very large cause of child death. Next over on the left is actually diarrhea. Again, huge potential for rapid decline, very large cause. Next down is pneumonia, a huge cause, slightly lower rates of decline across countries. But this idea that countries have shown you can have rapid decline gives us, I think, hope that it is possible to accelerate progress. Now, what I want to do is shift back to the question of how do you actually do that, drawing lessons from not the detailed engineering view of the health system, deliver BedNet to a child at risk, deliver the intervention for rotavirus, but rather one step back about what can we actually imagine as scenarios that could globally accelerate child mortality. And what we've taken is the econometric analysis, and we've done many different scenarios. What would happen if we sped up investments in maternal education? What would happen if we spent more money on healthcare? What would happen if we increased efficiency of health systems, if we can figure out how to do that? And the observation that we draw from this is that you can actually construct a scenario where the world achieves 15 per thousand in the year 2033 with a pretty reasonable strategy of three things. And reasonable, I think, within the reach from what we see in the evidence. First, accelerate investments and progress in maternal education so that we are raising average levels of schooling of mothers by 0.16 years per year. That's somewhat faster than what's happening in most places, but it's not a dramatically ambitious goal, but it's one that's certainly within the realm of what we've observed across countries. Secondly, if we raise the level of efficiency of health systems to the 75th percentile observed across countries. And the third component of this is to invest in innovation more, so R&D, operational research, so that we increase the pace of innovation by 25%. The combination of those gets us quite far. On the left panel, it shows that at the global level, we would achieve 15 per thousand in the year 2033. But on the right panel, it says that still all the countries in red would still have an under 5 death rate over 20. So you can achieve the 15 per thousand at the global level with just those three things, some acceleration and innovation, substantial progress on health system efficiency, and some modest acceleration in maternal education, but those countries in red won't achieve 20 per thousand. And that brings me to my last slide, which is, I think, if you take into account the intrinsic equity focus of having an absolute target, which I think is what would be a great thing if the world did adopt such a target. Think about the MDGs. The MDGs were a relative target, the same percentage reduction for everybody. It doesn't give special attention to the worst off. What's really exciting about establishing, if the world does, an absolute target, every country should achieve 20 per thousand, and the world, let's say, achieve 15 per thousand, is that it builds in a focus on the worst off. And from our analysis, the ones that would need special attention are the countries that I showed on the map in red. What do I mean by special attention? Well, I don't have a magic formula for that, but it's clear that even with dramatic progress on education, efficiency of systems, and as well as progress in innovation, those set of countries need an extra effort. And I think that's part of the truly exciting part of this call to action, namely, for the first time, having an explicit equity focus across countries. I think it's very much in keeping with some of the directions that Dr. Lake at UNICEF has been trying to pursue, and both within countries but also across countries. So I think our analysis suggests that you can really have a goal that's very ambitious, but it's achievable through that package of innovation, technical efficiency progress, and maternal education, but you will also need that extra effort in some countries. Thank you very much.
Flavia, we are very lucky because we have speakers who are all on time, and some are giving us 2-3 minutes. I think that we are very, very lucky. And Chris, thank you for highlighting all these main drivers to reduce child mortality. I think that this is very important. We are going now to see concretely what we can do, but also you give us a lot of hope that accelerated decline is possible, and some area where we can see the pathway now to achieve our goals. And thank you for that. Now, I cannot say that I will give the floor to the one I prefer because he's empowering women. But I have a bias for that, and I would like to give the floor to Naidoo, really the chair of the Global Alliance for Improved Nutrition. And Jay will give us some information on innovation to empower women and families. You have the floor.
Thank you, Madam Chair. And well, Tony, I don't know what I'm doing here because I'm not a scientist, I'm not a doctor, I'm not an economist. I'm actually an old ex-trade union organizer. So I feel a bit out of place here. But I do have a few thoughts about change. And having been an anti-apartheid activist, you know, that's a photograph of me at 2 years old. And the next photograph was in the 20s. In those days, we never had mobile phones with cameras. And listening to Minister Tedros this morning, I was struck by a conversation we had when I was in the Mandela cabinet as the Minister of Telecommunications in 1996. And we faced a similar challenge in Africa, that sub-Saharan Africa had less telephones than the city of New York or the city of Tokyo. And if we analyzed what were the problems of African connectivity, we understood that it was our problem that we had to solve. And so we convened a meeting. No one convened us. We convened the meeting of African telecommunication ministers in Cape Town in 1996. And we sat down to say, what are we doing wrong before we go out into the world and ask the world to support us? And I think that was an important lesson. And we asked ourselves, what were those roadblocks that were stopping us making the progress that many parts of the world were making? And the problem was not technical. It was navigating a political minefield of regulation, policy, and law, and the harmonization of the spectrum, which telecommunications would have needed in Africa. And that's what we did. We conceived an idea of a plan that saw us building regional hubs to build the critical mass that will attract private sector investment. Because telecommunications was being driven by private sector investment. But we had to ensure that the laws, the regulations, the policies would offer private investors the type of protection and about the safety of their investment or the return on capital. We had to understand how we had to harmonize the use of a spectrum. We had to understand how we would finance telecommunications and what was our concept of universal service. And so, if we looked at the issues then, no, I don't have one on me. So, if we look at the situation today, Africa is probably the fastest growing telecommunications market in the world. If one looks at the issues of mobile banking today, at the cutting edge of mobile telephony, it's African countries like Kenya that lead through the M-Pesa system. If one, later on today, you would be listening to something called the U campaign. It's the use of mobile telecommunications by civil society groups to ensure accountability by government to the commitments they are making in this roadmap around child survival. So there are enormous role models out there in Africa. What is missing is a marketplace that connects the donors and investment to opportunities that entrepreneurs who are creating solutions that help us achieve our objectives. And so my hope is that the roadmap will create a direct link between investors and people that are creating innovative solutions at the coalface within continents such as Africa, where the greatest problem exists today of child survival. And so what we need to do is remove the gatekeepers, what I call, friendly terms, the merchant class of poverty that we have in the world, that today absorbs so much of the resources that could be saving lives out there at the coalface. So what we have to ask ourselves is, what are the game changers? In telecommunications, it was very easy to understand that. It was a prepaid card that allowed an individual to decide how much they wanted to spend on a telecommunications service. So what are the right questions to ask ourselves today as to what are the game changers today in achieving the targets that we've talked about earlier? And it goes back to the issue of, that was me at 2 years old. At 4 years old, we were evicted from our home because of the color of our skin and the Group Areas Act. So I was a very angry young man. And I went as a young teenager to a meeting convened by the South African Students' Organization and a great charismatic leader called Steve Biko. And he spoke about us not being bystanders in a game where our futures were being decided. And that convinced many of us to take up the challenge of fighting for our freedom. And that's what we did, that we became the game changers. Today, when I talk to many civil society groups, they ask me, well, we don't have a budget to have a meeting or to launch a campaign. And I go back to our own history in the freedom struggles that we fought in Africa and say we never considered that there would be a generous donor out there waiting to pay for us to run a campaign on advocacy. So these are things that we've got to change within our own minds about how do we achieve the goals that we set ourselves. And so I asked myself the question, which are the two groups that really should be in this room today as part of this conversation? Because people like myself and Tony, maybe, we shift the age categories more to the upper ends. And I look at other campaigns that have succeeded. The global campaign around HIV and AIDS was an ability of young people and activists that combined with sympathetic governments and concerned governments and donors who were committed to doing something to create an extraordinary moment that brought us together, in spite of the difficulties that the minister raised, to make a dramatic breakthrough. And that's what we're asking for. What is that big idea that captures the attention of not just ourselves, but of the next generation who bear the consequences of decisions we have made? And today, as Tony had talked yesterday about the use of social media tools, it's that generation that will change the lives of people today that suffer as a consequence of diseases and the challenges of disease in our continent. So I want to go back to that issue of how do we bring young people into this conversation? And secondly, and most importantly, how do we bring women into the center of this conversation? Because if one takes Africa as an example, 80% of our food is produced by our mothers, by women. Yet they access 10% of extension services. They own 1% of the land. And so if we are looking at making changes and dramatic changes, we need to look at the issue of the empowerment of women, the rights of women, the incomes of women, and to address fundamentally the roadblocks, whether that is tradition, whether that is gender, whether that is religion, whether that is culture, that those things cannot be roadblocks anymore to the progress that we need to see. Because healthier mothers produce healthier children. And the data that shows us today that if one equalizes gender status, in South Asia, for example, the rate of underweight children under age 3 reduces by approximately 12 percentage points, meaning that 13.4 million fewer children will face malnourishment. So these are issues that I think we need to bring into the center of our political narrative. Now, one example of what we see happening in the organization I chair, called the Global Alliance for Improved Nutrition. In Bangladesh, the incidence of anemia and micronutrient deficiencies are probably 70 to 80% of women and children under 5. Working with a company called Renata, a pharmaceutical company, and with BRAC, which is a big social organization, we were able to produce a box of sprinkles, which contains 15 micronutrients, which is dispensed through the network of BRAC and their 65,000 health workers for $1 a month, and which contributes up to 1/3 of the required daily allowance that a child would need. So we can find a way to work with private sector companies. We can find a way to harness the markets in a way that meets the needs of the poor. Because if one looks at the malnutrition challenge that has been reflected on quite often in the discussions over the last 2 days, that malnutrition challenge is a big part of the disease burden that leads to infant and maternal mortality. So as we're looking at scaling up the roadmap around child survival, let us also find a way of linking that roadmap to the roadmap around scaling up nutrition. That these two things are part of one program and roadmap. And I'm hoping that under your leadership, Tony, that we will be fearless, that we will be courageous in challenging those roadblocks today that hold us back. So we have agreed a global governance framework here today. We have to make some really tough choices about it. But we need to prioritize those high-impact interventions and scale them up. Our support needs to go to countries where there is demonstrable political will and commitment. And that support has to encourage, fundamentally, a robust, independent civil society that can change social behaviors of whether it is mothers, whether it is fathers, or whether it is the corporate sector or our governments. Because ultimately, it is that approach where we are able to cut through the political minefield that we will achieve what we have set as very noble goals and intentions in our meeting over the last 2 days. Thank you very much.
Thank you very much, Jay. I understand that having grown up with people like Steve Biko or Mandela, it's normal that you are this big advocate and great advocate. And what you have said is very important because you have been able to show also how, one thing I will come back to that, but how young people and women need to be really brought in this fight. But I disagree with you when you say that Anthony Lake and you yourself are too old now going to one direction, because I am part of this group too. Maybe we need to negotiate after on this issue. Thank you very much. Now, Flavia, you can continue.
Take it to the next. Thank you very much, Awa. I should say Honorable Minister of Senegal, because that's what she is and what she represents, so passionate for the health of women and children in the world and in her own country. I hope the audience here is realizing that this is the best panel of the day and certainly the best panel of the workshop. So let's continue. We have a couple more speakers that have interesting message, and then we hope that we continue keeping the time, and we are planning to have questions from the audience. The next speaker is Dr. Joy Lon. She is well known to many in the room. She's an African-born pediatrician and perinatal epidemiologist, and she will focus our attention on the 3.1 million newborn deaths, how to change the trajectory towards death survival. Joy, please.
Thank you, Flavia, and good morning, everybody. It's such a privilege to be on this platform. It's a wonderful event, and it's a special honor to follow Jay. So I live in Cape Town. I have followed the heroes of the apartheid age, and it's really great to follow you now on the platform. So this meeting, I hope, is more than a meeting. I hope it's a moment for a shift, really a paradigm shift. And a shift we have heard about accelerating progress. But I hope also accelerating change in perceptions. So one of the beautiful, and some clever campaign person obviously thought of this, is the focus on the 5th birthday. A birthday, a celebration. We're celebrating more children having birthdays. Well, I'm here today in my funeral dress, my Ghanaian funeral dress. And in many ways, when we've talked about mortality, we have thought about funerals. And I would like to paraphrase Richard Horton, who's unable to be here, but is very interested in this event. And he has said that a marker of progress is when a society recognizes that a preventable child death is not acceptable. But a marker of civilization is when they recognize that a newborn death is preventable and is also unacceptable. So when we think about birthdays and we think about funerals, when you go around Africa, I spent 4 wonderful years in Ghana, and I went to many funerals. But people don't put dresses on like this and go to funerals for children, usually. And they never do it for babies. So the other side of that story is, in child health and in newborn health, we're actually coming from having no funerals. And it doesn't mean that people don't grieve. It means that somehow it's still accepted in society. Because when you hold a funeral, it means that that death is really recognized as something that shouldn't have happened. And so we want to go, in fact, from no funerals to funerals. That was part of how HIV moved forward, getting out there and showing that people were dying. And then from that, we want to go to having less funerals and to celebrating birthdays. So I think that that's a fantastic paradigm shift, and I think that we have started to make that in maternal, newborn, and child health. So if you look at the remarkable progress that we're now celebrating for maternal mortality, a couple of years ago, Women Deliver here in Washington, MDG 5 billed as the most off track. And here we are now, 4.2% per year. And you know that maternal death has really become unacceptable. I travel all around Africa at the AU meeting in April this year. That was the single largest message, so clear. Very high-level people committed to it being unacceptable. Child death, now coming down at 2.5% per year. We still have way to go on it being unacceptable, but I think there is a real move on that. Neonatal deaths, only coming down at 1.8%, much slower. And why is that? Almost everybody who has come to this platform has talked about the need to do something about neonatal. We've got a very short amount of time to think about that, but I want to ask the question, why is it slower? Is it slower, as some people maybe are almost suggesting, because it's too difficult? We don't know what to do, we can't do anything. Is it because we have got some things to do and we've really been trying and we haven't made a difference? I don't think it's that either. And so what I would like to set out is that we do have a moment in time that is completely different, but this attention is recent, really recent that we've started to look at this. And in fact, interestingly, listening to people yesterday, it was the Asian ministers and also Tedros who were the people who were concrete in what they talked about for newborn deaths. It was the people from the countries who were doing things, Bangladesh, remarkable, who are moving. and actually less from people at the global level. So I think we need to change our languaging on this. This is the slide from the roadmap that Amie presented earlier, looking forward at the trajectory as it is at the moment and predicting 35 per 1,000 child deaths in 2035, but aiming to accelerate and the possibility of the 20 per 1,000 that people have talked about. But you know what? If you take out the current progress for neonatal deaths and you don't change it, look what happens. By 2035, the neonatal deaths would be 15. That is around 3/4 then, instead of 40% of the under 5 deaths. It's around 1.5 million deaths still. So we have no choice. We really do have to do something different. And we really have to grasp what we're going to do, and we need to find ways to mobilize to do that. But that global figure hides major differences in regions. So if you look at this, indeed, Europe, with the lowest neonatal mortality rate, around 3, 4, 5, is still making the most progress. Africa, with the highest rate, still making the slowest progress. So this meeting is all about accelerating to the MDG target and beyond. How long would it take? What year would it be that these regions reach the same neonatal mortality rate as you have here in the US or in the UK, where I was once a neonatologist? So for the Americas, Western Pacific, it isn't too long. For Africa, 150 years. Now, I stand here as an African. I was born in a bush hospital in northern Uganda. I don't have time to tell the story, but my mother had a C-section, no running water, no electricity. I survived, but every day African babies don't. I survived because people shouted for me, and they believed that I didn't have to die and my mother didn't have to die. Us Africans need to say that that's not acceptable. 150 years, it's longer than it took the US and the UK to do that. They did it in 50 years with less technology and with less focus. We can do better, and we must do better. And we can do better because there are African countries that are doing better. So if you look at Malawi, remarkable. One of the lowest income countries in Africa, up until a couple of years ago, one of the lowest human resource densities in the world. And yet they're on track for MDG4. They're reducing neonatal mortality rate at twice the rate of the African average, and it's speeded up. This is the figure from 2000 to 2010. Why? Well, go and talk to the colleagues from Malawi and read the paper that they have published with us in Health Policy and Planning this week, looking at why. A decade of change in Malawi. What have they done? And one of the things they did was people were investing in maternal health, and they made sure that when things were being done for the mother, the specific things like resuscitation, kangaroo mother care, were also done for the baby. What about the countries with the biggest reduction in numbers of deaths? So everybody has talked about the focus on key geographies. The same countries that have the high numbers of child deaths, obviously because of large populations. But if you look at change over this decade, you see something interesting. So if you look at those countries that have their numbers in green, they have improved in their standing over the decade. And those countries have addressed survival risk, but also fertility. Brazil has dropped the number of births by about 0.6 million per year. So this is really a great synergy. It's not a competition along the continuum of care. Each input, the reproductive input, the maternal input, and as we go through, feed into progress overall. Now, why has it only been recently that people have noticed the neonatal? Some of it is because we haven't had good data, but some of it is also how we packaged our data. So up until 2005, when the Lancet Neonatal Series came out, this was the global pie for causes of child death. Single biggest cause, other. Great. How do you run a program for other? Not so helpful for programs. Next biggest, perinatal causes. What is a perinatal cause? It happens to be the ICD chapter grouping. Most people don't necessarily know what that is. So moving forward, the data that Bob showed, that we started with WHO and published in The Lancet in 2005 and every year since, having causes for neonatal deaths that are programmatically relevant by country each year has been a critical step forward. And having the trend data that Bob has led that we published in Lancet last week is really critical. Pneumonia, number 1, preterm birth, number 2, cause of child death, not just neonatal death. So this is a huge number, 1.1 million. That's double the number of deaths due to malaria in childhood. And yet, we don't often hear people talking about this and solutions. So as we look at the rate of progress and how to be game-changing in that rate of progress, we can see that for tetanus, we have had remarkable progress, almost 10% average annual rate of reduction per year. And it's tempting to think, oh, well, that's because there's an immunization. But you know, there was an immunization for 50 years, and we missed 2 elimination goals. What made a difference, as well as getting money, was using data. Using data in districts, targeting districts, really thinking too about the women's side, the demand issues for tetanus toxoid during pregnancy. Really critical issues. We can learn a lot. But these 3 causes that are moving the slowest are the biggest. Preterm birth, number 1. The birth complications, what we used to call asphyxia, and the infections. More than 2/3 of neonatal deaths. And you know what? We can start with public health interventions. We do have solutions there. But to move to these 3 big causes, we need workers at all different levels and some basic commodities. And there is no greater test of a frontline worker than whether they can deal with a small baby, especially a preterm baby. That is the test that we should judge our frontline workers on, and also what we should judge our politicians on, because that is the weakest citizen that deserves a bigger voice from us. But I want to emphasize, and Chris made this point, that innovations are really here, even over the last 3 or 4 years, with the Helping Babies Breathe work on resuscitation, with work on neonatal sepsis case management, and indeed chlorhexidine for the cord, and with kangaroo mother care that we know can halve deaths for preterm babies. Antenatal steroids injections could reduce deaths in preterm babies by around 400,000 a year. Kangaroo mother care by around 500,000. These are things that are very low coverage and that we need to be moving on. And so I would hand to you this report that I hope you have, because we haven't got time to cover it. But I hope it puts to death the idea that we don't know what to do for preterm birth. We do. This survival gap, the 1090 survival gap between rich and poor countries for preterm babies, is not acceptable, especially as we have solutions and these can be prevented. For those babies dying of birth asphyxia, this costs more to do emergency obstetric care, but it is value for money because it's also saving stillbirths and maternal lives. You get a triple return on the same investment. But that investment has to be quality care at birth. If we look at the great success in India and many countries in bringing births into facilities, quality is lagging. Then if we look at the 3rd cause of neonatal deaths, infections, we have solutions here as well, both prevention and care, yet they remain at low coverage. And so I have the 3s for you. 3.1 million deaths, moving too slowly. 3 main causes, we have solutions. 3 reasons why we can change this trajectory. And the reasons are exactly the shifts in this roadmap. This is a huge cause. The coverages are low. We have program platforms in many cases, and we can change this. But I want to emphasize that we need also to change the level of commitment to this. And this slide, I don't have time to go through in detail, but it's in these fact cards you can pick up. And we know that funding has gone up for maternal, newborn, and child health. But if you look at donor databases, only 0.6% of donor funding for maternal, newborn, and child health has the word newborn in it. And it's usually in the phrase maternal, newborn, and child health. So we still aren't funding the things that will save lives. And so I finish by saying that 77 countries have reduced their NMR by 1/4 in the last decade. There are countries that are bending the curve. Many of those countries It's been critical to them being on track for MDG 4 by also reducing neonatal deaths. Changing the trajectory for newborn survival all over the world is possible. Countries have shown it. We have products in hand. The question to us is, will we deliver on that? Thank you.
Thank you very much, Joy, for the passion and for the focus on the early part of life that, as you have demonstrated, is so critical. Our last panelist is Cristian Baeza. He's currently the director of the Health, Nutrition and Population at the World Bank, and he's going to address on one of the critical aspects of this agenda, which is accountability and measuring the results. And I'm going to count the minute very, very firmly on this.
Happy that you made me accountable, no problem. I'll try. Thank you very much. And I want to open by saying that we at the World Bank enthusiastically support and want to move forward with the call of action. And I want to say that because it was about time, and because we believe that this might allow us to put Humpty Dumpty together again. And I will come back to that. So I want to really congratulate USAID, UNICEF, the government of India and Ethiopia for having convened us and having injected the enthusiasm I have seen. It takes a lot to make a child survive. It also takes a lot to make a child thrive, and that we need to keep in mind. It takes access to effective nutrition and to a continuum of care in reproductive health, maternal, newborn, and child health. But it also takes an educated and healthy woman, a woman who is empowered to decide on her own fertility through access to effective family planning. And I think in the bank, and I think collectively, we see the challenge of child survival as a challenge of putting all this together. Is a challenge of MDG 1 in nutrition 4 and 5, who in our view has been neglected MDGs in the aid architecture, and the challenge of MDG 6, we've been successfully mobilizing attention and resources. When thinking about this panel, we decided to share with you some of our own lessons, some successes, and many mistakes you go through this route in terms of achieving results. And we came up with 6. The first one is clarity on what is a result. And getting money and expending money is not a result. Changing life of the people on the ground is a result. Improving the life and survival of a child and make that child thrive in life is a result. And we get confused sometimes, and I think we need to keep that very clear. The second is certainly being able to measure the results through good modeling, but to actual good data, but also being able to convey this, the measurements and the metrics in a way that is compelling, that actually means things to the normal people, and it is able to balance the complexity of the measurement and the metrics with the power of compelling people to action. And we often, in the efforts of accountability, neglect that. We are enthusiastic about the metrics of saving lives. I know that many of you might not be. We believe that it's been a very compelling metric. We are also very wary about being honest and transparent and robust in the way we are doing these compelling metrics in the future, and we look forward to work together on improving it. The third lesson for us is the capacity to generate a strong evidence of what works, not only in the labs, but also on the ground, but then the capacity to stick with it when we generate policy. And I think we do have a significant gap. We have the evidence. How do we convey the message in a way that is also compelling to our policymakers so we can stick with it when we actually make global and local and country-level policy. The fourth for us is an effort to link the resources to the results, meaningful results. And in this, there has been a lot of discussion about results-based financing. We do have a very significant effort on results-based financing, almost $600 million committed in our operations in that. But the challenge in the results-based financing discussion is that it has been a discussion about donor funding. And as important as the donor funding discussion is, it is marginal. What it really matters is a discussion about effective allocation at country level and a partnership between the global community and the country community to make those commitments and also those resources be effective. The fifth for us is the whole call and the effort to make ourselves accountable. And that's incredible. The global community has made an effort. But I think the trick, and we think the trick, is to not only make ourselves accountable, but to provide to society, to provide to citizens the effective instruments to actually demand our accountability and our compliance with that accountability. And that includes the Commission for Accountability and the Independent Review Panel, but it also needs to include effective mechanisms of collaboration with CSOs on the ground. So we actually go through the enlightening and sometimes challenging and painful reminder that we are not complying with what we are promising. And I think we need to put that. We would like to salute also the efforts of independent entities such as IHME in putting this, it's sometimes putting a painful call to us that we have challenges in measuring and challenges in the metrics. And I think it's a welcome challenge because that's the way you actually renovate your commitment to good methodologies and approaches. Now, an emphasis I want to do is in the sixth point, is the issue and the need to invest in all components of the result value chain, and not on the ones that are easier to communicate, or the ones that compel donors the most. For a micronutrient supplement to have the full effectiveness during pregnancy, we certainly need the macronutrients, and we need to go for it for sure, but we need a whole bunch of other things to be in place. They're not so fancy, they're not so compelling sometimes, but they need to be there. We call them the glue. Nobody talks about the glue as a fancy issue, but it has to be there to put the system together. We certainly need demand, mothers to demand it. We need motivated and trained workers. We need basic infrastructure. We need effective procurement. We need functioning logistics, and so on and so forth. We need them all, not only the part that compels taxpayers the most. So in other words, we need our old and well-known health system strengthening and health systems approach to this discussion. And when reviewing, I'm not an expert in maternal and child health, but when reviewing the data, and there's a discussion about how the success of the vaccine efforts, or the malaria prevention efforts, or the HIV vertical transmission efforts, and others, allow us to have incredible progress on under 5 mortality. When we look at that data, we look at the challenge of neonatal mortality. And we wonder why it's taking so long and why it's so difficult. And there's a couple of words. It's health systems. Because perinatal achievements are going to take a huge effort on perinatal care. And that requires all the things together, working together. So it is imperative that we make ourselves accountable, and the founders and civil society make ourselves accountable for meaningful results, but also for commitments and investments in the whole value chain, in the whole health systems, no matter what fancy or not fancy it is. We need to have certainly the commodities, but we need to have much more, all parts of it. Finally, I would like to say that child survival is about good health of children. And it's not only about health care. So we, the healthcare community, and I am part of that health community proudly, cannot make the mistake we made in the past of kidnapping the MDGs as if they were a healthcare MDG. They belong to all of us, to all sectors, because it's equally important, as it was shown today that we invest in healthcare, in the continuum of care, but we invest in in girls' education. We invest in clean indoor. We invest in nutrition substantively and decisively, as we have not done so far. And we continue this journey together from healthcare to health. You know, I'm old and getting older by the day. But I was trained as a public health specialist 30 years ago. And what I learned then, it is about not only healthcare, it's about the whole community. We need to come back to that conversation because we have been very focused on the issue of infant mortality or MDG 4 and 5 as if we're only a healthcare discussion, and it is not. And the evidence is showing that. So that's the reason why we are so enthusiastic about this call, because we believe that this call of action includes the equity dimension as never before, but it also responds to a little of a challenge we have had in the recent past. Our enthusiasm made us move decisively, but fragmentedly. And this call has the potential to move us and put Humpty Dumpty together again. So we welcome that work together. Thank you very much.
Thank you very much, Cristian, for the last intervention and for putting the emphasis on the glue. Colleagues, I know in the room there is a lot of interest and excitement to speak. So we have 2 microphones here at the front that are for posing questions and making comments that I know many of you will have. If you would like to do so, please come forward. In the meantime, allow me to make a couple of comments that are really building on the conclusion where Cristian left, that the great potential that this meeting has and this call to action has is to focus on the integration. And Dean Frank yesterday mentioned this when he was commenting on the roadmap, and he really spoke about the integration of the preventive measure and the curative and treatment measures. And one of the critical aspects that we have that gives us the confidence today that this great call is possible is that we have some preventive measure that we have not factored in those graphs yet. We have, for diarrhea, for pneumonia, vaccines that have not yet been used at scale, pneumococcal and rotavirus vaccine, that no doubt will enable us to accelerate much faster. And here I know there are several Gavi board members like myself in the audience that are very keen and very passionate about that. Now, we have only 20 minutes, so what I'm going to do, I'm going to give the floor to the speakers. I'll move back. As I move forward, it means your time is up, because I've been many times in this setting when some colleagues ask comment and question, but they take more time than the speaker themselves. So I like to start from a colleague that yesterday had his time very much curtailed, Professor Butta on this right. Please, Zulfi.
Thank you. Thank you very much, Flavia. I have a comment and a question for Chris Murray. So my comment pertains to something that we haven't spoken about since yesterday, and I think it's important to underscore in the context of newborn deaths. Both Bob this morning talked about the reclassification of newborn deaths as intrapartum-related complications, which used to be called birth asphyxia. And what we haven't spoken about, and I think is a critical component of the discussion, are the intrapartum stillbirths, which basically are an extension of newborn deaths. So if you take the numbers, intrapartum stillbirths that arise because of the same reasons that cause birth asphyxia, and you add them to the number of newborn deaths that occur because of birth asphyxia, that pie, that proportion will grow to the largest number that we have. And I think they should very much be part of the equation. And it's unfortunate that despite the fact that we put the numbers out last year, the advocacy was made, that there hasn't been much traction in policymakers. So that's the comment. Chris, my comment to you is, I think it's fantastic analysis, and I was intrigued by the component, the proportion of change that you are projecting over the next 20, 25 years that may come out of the innovation piece, which was largely around, as I understood, the implementation research. what proportion of that, in terms of modeling and anticipation, could also come from not just efficiencies of delivery, but also new interventions, which potentially can address things that currently we don't have solutions for. And I was thinking not just of things that we currently have in the pipeline, but things like maternal immunization. I mean, there's enough evidence emerging that that simple intervention could potentially impact a huge proportion of newborn deaths and young infant deaths that currently are not being targeted.
Thank you very much, Zulfi, and thank you for not forcing me to come up. The next question or commenter on my left from Save the Children, please.
Thank you, Flavia. Simon Wright from Save the Children UK. It's just also a point about the equity target. I think it's probably debatable about whether setting an absolute target for every country really will focus the world's attention on those countries which are furthest from the target. But actually the point I wanted to make was around in-country equity. And I think the absolute lesson that UNICEF's work has shown us is that national average targets do not reduce in-country inequity, and in fact may even increase them. So the question is really why we're not learning the lesson from the MDGs, and again talking about a target of a national average. And what we need to say, we think, is that a country could only possibly succeed if the target is achieved in every segment of society. And that should probably be wealth quintile. That's what DHS surveys show us. But it probably also needs to be ethnic groups and rural-urban. But we really should have moved on from national average targets. And I think whatever comes needs to reflect that.
Thank you very much. I'll take one comment from the left. Please introduce yourself. I don't know you. I know many people, but please.
Yeah, thank you very much. My name is John Lane from the Water Supply and Sanitation Collaborative Council. You don't know me because I'm not a health person. I bring greetings to you all from the water, sanitation and hygiene community. And we have a very similar global movement called Sanitation and Water for All, and a number of the leading organisations here are also members of that. So I commend the work you're doing. My point is about diarrhoea. We've seen diarrhoea throughout these 2 days, right up there as one of the headlines. And in sub-Saharan Africa, it's #1. And the intervention that I'm proposing, but that I haven't heard anybody talk about at all in these 2 days, is a hole in the ground. It's called a toilet. And the work that sanitation and hygiene can do to work with yourselves in health is profoundly important to make a really big impact on about 1 million out of those 7 million child deaths. My question to each of you in the room is, when you give a child an immunization, or when you give a child a bed net, and then you send them home to live in shit, what do you think about it? Because they will die of diarrhea. I appreciate that a toilet is not a glamorous item, and yet, as Nelson Mandela tells us, are we to judge the importance of an issue by how glamorous and attractive it seems, or by how much good it does to how many people? And on those criteria, sanitation, hygiene and water must be absolutely essential components of all of our strategies for child survival. Thank you very much.
Thank you very much for the passion, and welcome to our meeting. Next time we will recognize, but please note that the countdown indicators and coverage include water and sanitation and the hole in the ground you mentioned. Next on the right, please.
Thank you.
Introduce yourself.
Okay, I'm Glenn Moeller from Papua New Guinea. Joy Lawn showed us the slide that would show us that neonatal deaths would account for 3/4 of the total child deaths if we keep on going in the way that we're going, without bending curves. And I fear that that graph will be the future unless we have a complete paradigm shift about looking after the neonate. And the shift has to be to maternal health care. The problem is that most people in wanting to do something about child survival are pediatricians. Pediatricians have nothing to do with neonatal survival in developing countries. It's all about midwives and looking after women. So unless we have this complete paradigm shift in terms of actually what we do in looking after our patients and our people and our communities, then Joy's graph is going to be the future. So let's switch off the pediatricians and switch on the midwives, please, and put our efforts into maternal health care, and then the neonates will survive.
Thank you very much. I know there are many midwives in the room that will be very pleased. Our last question is for Professor Vinod, because we also want to have some answers to the question. Please.
Thank you, Flavia. I'm Vinod Paul from India. Two points I'd like to make. We learned from the podium the MDGs are relative and the call to survival goal is absolute. I think one caveat that we may like to add, colleagues, is that it should not be seen as less than 20 goal for every country. The countries which have a higher than this should not only aim at 20, but below. For example, for India, we can look through and see that in the next 3 planned periods by 2027, this goal of less than 20 under 5 mortality is achievable. And with all the things that are happening in India, therefore, there's a need for absolute goals for each country embedded in this call to action. My second point is in regard to the presentation, Joy, that you made, great presentation. I think what must also be emphasized, which you implied but should be stated up front, is the need for facility care for small babies. It's kangaroo care also gets introduced in the facility. It's not something which drops from heaven. There is a need for looking after babies who will be asphyxiated to be seen, to be looked after in the facility, infections to be treated at facilities. There's a huge component that can be achieved in the community. And we know it from Dr. Abebang's work, and India is doing that. But I think not to list facility care for sick babies and small babies is something which we like to course correct, because there are investments involved in that, human resources and commodities are involved in that, and that should be one of the pillars of care. Thank you.
Thank you very much, Vinod. The last question on the left is from the colleague here. I'm not taking any more.
Thank you. Eduardo Espinosa, Vice Minister of Health from El Salvador, Central America. Nosotros introdujimos la vacuna contra el neumococo para reducir las complicaciones por neumonía y las muertes infantiles por neumococo. Fue muy efectiva, pero estamos pagando por la vacuna contra el neumococo casi tanto como todas las demás vacunas de nuestro programa de inmunización. Eso es una historia. Y te estamos pagando por medicamentos antirretrovirales el 8% de nuestro presupuesto para medicamentos. Con 12 enfermedades como VIH, no podríamos cubrir más enfermedades. El primer punto es más justicia por los fabricantes, de parte de los fabricantes de medicamentos y vacunas para nuestros países. El segundo punto es que no he escuchado énfasis, perdón.
Yes. Sorry that he asked me to help him in the translation. He made 2 points in terms of he wants to make 2 points. One is first in terms of the price of medicines and especially in terms of vaccines. Salvador, the Vice Minister of Salvador, he's saying that the country introduced vaccine against pneumococcal vaccines, but the price of the vaccine is the same total cost of the vaccines that they already have in the national schedule. And the second point is that in terms of antiretrovirus, is the 8% of the budget for medicines in the country.
Only 12 more disease, 100% of our presupuest. El otro punto es el embarazo adolescente, que no he escuchado. Durante la epidemia de influenza A H1N1, las muertes por H1N1 se concentraron en 3 grupos: madres adolescentes y niños menores de 5 años. Los niños menores de 5 años eran también hijos de madres adolescentes. Entonces me parece que es un punto que debe ponerse en consideración.
And the last point is pregnancy in adolescent, and especially now with the H1N1 epidemic, the ones who were more affected were children, that they were from mothers, adolescents, and also pregnant women were affected.
Thank you very much.
Un punto para las organizaciones basadas en la fe.
Muchísimas gracias a usted por la contribución. Thank you very much. He put the focus on a very, very important aspect, which is pregnancy in adolescent. For those girls that, in fact, are girls themselves that are not really ready to become mothers and for which we have higher complication of mortality for themselves, but also higher complication and less ability to care for the children. I have heard a few questions and I like the panel. I'm sorry, sir, I really said no already to somebody else. I like to have some question to the some answer to the question that were posed, and we are already a little bit behind schedule. So there was a question that came in your direction, Chris, that I'd like you to address, please.
Sure. So
as you speak, it will activate.
It will activate, great.
Zulfi, what I was describing as innovation definitely includes technical innovation as well as how you deliver things. Mm-hmm. So I hope I didn't give the impression that it was just the operational research side. I think if you look historically, why do we see such a trend due to innovation? New vaccines, new treatments have been an important part of that. And so to continue that trend of innovation requires us to have that as well. And I think to accelerate it would be great.
Thank you, Chris. I also heard a number of questions that came your way, Joy, in terms of the neonatal mortality, and if you can please address a few of them.
Well, thank you all very much. I think the message to the organizers was that 12 minutes wasn't enough to cover 40% of neonatal deaths and 2.6 million stillbirths and give solutions. The second message was I completely agree with all those points. So Zulfi, on the stillbirth agenda, there was actually a slide from the stillbirth series, but it probably went a little quickly with the intrapartum care, so the maternal obstetric care, having a triple return on investment. The maternal lives saved, the big group, the 1.2 million intrapartum stillbirths, as we published in the Lancet Stillbirth series last year, and then also the neonatal, particularly the intrapartum complications. So on the stillbirths, totally, on the maternal care part, that's critical. And actually, I really encourage you to get this supplement in health policy and planning and the fact cards, because I think we have this idea that the neonatal agenda has been run by pediatricians who do things at community level. In fact, the countries that have done quite well, particularly Malawi, has hooked on the maternal agenda, and they started with facility-based newborn care, particularly KMC. So they have the highest rate of preterm birth in the world, according to the estimates we published in Lancet last week, partly because they made the mistake of having their own data, so that put them higher. But in Malawi, they have the highest rate, they have huge problems, and yet they're still making that progress. And it's really because of that strategy they've taken. We need to get past a dichotomy. We need the facility and we need the community. And we need to make them both work together and move forward. And in both places, we have frontline workers that have a very important role to play. And we need to empower women and communities to do their part, both for the mother and the newborn as well. Thank you.
Thanks, Joy. I want to ask the other panelists whether they have some other comments to make.
Well, yes, certainly I think that the issue that confronts us today is how to take the intellectual capital of a room like this with all the science, the technology, the business models, the data, and connect that to the streets and villages and slums where these deaths are taking place. And I think that's the critical connection that we need to make. And in that, the real elephant in the room is government. If you look at the question of resources that will be spent here compared to what we want to raise from donors, I mean, if we can improve the efficiency and strengthen the health systems of governments and make them more accountable for the type of targets that we are setting here, and building a smart partnership with civil society that improves that accountability from a grassroots upwards, from bottom up, and then looking at the way in which we work with sectors such as the private sector in a way that makes markets work for poor people. I think that combination of linking, for example, malnutrition and linking the roadmap on child survival is critical for us.
Thank you. You want to make a comment, final comment?
Yeah, I just want to make a comment that is squarely in our space, which is fiscal space. I think the issue that El Salvador is raising on affordability is a critical issue. I think we sort of grew accustomed to growing our ODA for health in the last decade at 16% a year. Those times are gone. And I think the issue, and it will be much less than that. And the issue of really engaging with countries in their own funding and their own priorities in creating the fiscal space is very crucial. I think the other side is the price affordability. I think the efforts that UNICEF, UNFPA, the Commission on Commodities and others is really crucial in that sense. But my own assessment, and not necessarily of my organization, is that because we had a decade of such a success in focusing the solutions to these problems through increasing donor financing, we have not yet done all the effort and our homework on actually ensuring that the fiscal space is there when countries graduate from whatever thresholds we use for ODA. And that's a pending agenda.
Thank you very much, Cristian. It's an agenda that clearly requires a lot of work and where I think the agency you lead can play a very critical role on the sustainability of financing for health.
Thank you for the promotion. I don't lead it yet.
One comment from Amie, and then I'd like to give the Honorable Minister some space, please.
I think several of the comments that were raised really are highlighting the importance of addressing the neonatal conditions, addressing WASH, looking at nutrition, all of these critical aspects that somehow have gotten hived off or fragmented. And as Cristian referred to, sort of that Humpty Dumpty that has fallen apart. And I think part of this call to action is about recognizing that actually we all fit within one tent. And by focusing on this cross-cutting goal of how do countries accelerate their rate of reduction of under 5 mortality, you cannot do that unless you address neonatal conditions. You cannot do that unless you're addressing solutions like WASH, immunization, and nutrition. And it is that kind of looking for that larger objective, which tailors to each country and the specific conditions and solutions for each country that I think brings us all together and starts to ensure that we really are addressing the most effective ways forward.
Thank you, Amie. Now, Awa, you started us off. I'm sure after this discussion you have some reflection.
I think that, in fact, I will take my hat of Minister of Health and just say that for all I have heard, it seems to me that we need also to really look at the empowerment of communities. Because things will change only if communities are able to play their role. And I would like to say that in Senegal, we have been able, these recent years, to try to pilot more and more community experiences, but we want to go to scales. For example, case management at community level of all the main issues we have. The issue of family planning, the issue of nutrition, but also water and sanitation at community level. The issue of also preparedness of birth with pregnant women. All this needs to be done at community level, and we need to really ensure that they have all the power to do that. I would like to say also that at community level, you have also a lot of partnership possible. And I would like to thank for Senegal, USAID, because they have done a lot of work and support us, UNICEF, WHO, and a lot of NGOs there. So I think that we need also to really work and try to have a lot of partners, and partnership is key. A last point is this time also to be the sort of ambassador of not big countries, because when we look at the call for action and we also in the roadmap look at big countries to make a difference, I think that small countries also need to be supported, and this is my plea for this audience.
Thank you very much, Awa, and I think your call resonated very well. Colleagues in the audience, our session was entitled Ending Preventable Child Deaths Within the Continuum of Care. I think the session elaborated quite well on what that continuum of care entails in terms of the intervention that are crucial to make progress. I think my co-chair expanded in the second dimension of the continuum of care when we published this concept in 2005 in the first report that WHO published on maternal and child health that was entitled Make Every Mother and Every Child Count. We described the second dimension of a continuum of care as the continuum that starts in the home, in the family, and continues in the community and in the facility at a different level of health care. And I think the discussion today has elaborated on how each part of that second continuum is critical to make the progress that we are calling in this audacious call to action we have today. My task is now to thank all the panelists, thanks all the colleagues in the audience. I know there were many, many more questions. Please take the time at lunch to elaborate this discussion and do come back for the second part. It will be as exciting as it has been so far. Thank you very much. Thank you, panelists.